Thank you very much, Mr. Chairperson. Ladies and gentlemen, it is my great pleasure to present my data in this prestigious session. My disclosure information. The assigned topic to me was atrial flutter after cardiac surgery. But why atrial flutter alone, not atrial fibrillation? It might be because most of valvular atrial fibrillation presents as atrial flutter or atrial tachycardia. The potential mechanism is related to significant atrial structure remodeling in valvular atrial fibrillation. A long time of hemodynamic stress on atrium changed the property of cellular ion current and shape of action potential, reduced their conduction velocity, and increased the atrial size. And bigger atrial size is a volume containing their more and more sustaining reentries. And to maintain fibrillation, a certain amount of myocardial mass is required. We call it critical mass. As we cut the myocardial mass serially, fibrillation changes to regular tachycardia at a certain point and eventually terminated. In this surgical specimen of atrium taken from the patient with valvular AF, there are a lot of fibrotic areas and smooth muscle components, disarrayed gap junction, and PAS positive Purkinje-like cells. Therefore, in spite of big atrial size, actual critical mass is quite low because of a severe matrix remodeling in a patient with valvular AF. Therefore, valvular AF easily changes to atrial flutter or atrial tachycardia. Moreover, the critical mass becomes even smaller by distracted region after concomitant MACE procedures. The hemodynamic factor is also important in surgically corrected valvular AF. We previously reported the poor rhythm outcome of AF ablation in patients with elevated LA systolic pressure or LA pulse pressure, which is related to LA compliance. However, the hemodynamic burden might be relieved by cardiac surgery in patients with valvular AF. And we found AF ablation itself increased the left atrial pressure at the repeat procedures, especially in patients who underwent empirical extra PV LA ablation. And also, we measured the 1-year follow-up echo parameters instead of invasive LA pressure measurement in this study. And the stiff LA physiology was observed in 3.7% of overall patients after AF catheter ablation, and was associated with diabetes, underlying diastolic dysfunction, and empirical extra PV LA ablation. And the rhythm outcome was worse in those patients with stiff LA physiology. Okay, let me introduce our previous study regarding catheter ablation of valvular AF atrial tachycardia in patients who underwent valve surgery. These are the patient characteristics, and we compared the 77 valvular AF, and all those were corrected valvular AF, and over 2,200 non-valvular AF. All the patients underwent catheter ablation, and among 77 patients with valvular AF, majority underwent mitral valve surgery, and 14 of them underwent concomitant MACE procedures. When we compare the rhythm outcomes of a catheter ablation in patients with hemodynamically corrected valvular AF and those with non-valvular AF, these Kaplan-Meier curves show no significant difference between the two groups regardless of concomitant MACE. So we guess it was because these valvular AF patients were hemodynamically corrected by surgery. However, we have to consider the selection bias of valvular AF patients in this study. And this is a mapping finding of atrial tachycardia in patients who recurred after MACE procedures, and 42% show the PV reconnection, and the block maintenance rate of linear lesions were pretty low, especially the maintained block rate of left lateral isthmus and cable tricuspid isthmus were only 16%. And the mechanism of atrial tachycardia were macro reentry 63%, focal 26%, and unmappable 11%. Let's discuss the low maintenance rate of conduction block after MACE procedures. It is very low. And all those MACE procedures were conducted with cryoablation. How's the bidirectional block maintenance rate at the AF catheter ablation and non-valvular AFib. In this review of repeat procedures, bidirectional block maintenance rate of roofline was 64%, posterior inferior wall isolation 35%, and anterior line block rate was 40% after RF catheter ablation. So bidirectional block maintenance rate is less than 50% in recurrent patients who underwent AF ablation by current technology. What about after AF surgery? In this graph, blue bar represent bidirectional block rates at repeat procedure after RF ablation, and the red bar represent bidirectional block rate at the second loop mapping after AF surgery, recently published by Bulabar. Actually, catheter ablation was better than AF surgery in cable tricuspid isthmus, roof, and anterior linear ablation. However, PB isolation and LA posterior wall isolation rate were much higher in after AF surgery compared to catheter ablation. What is the mechanism of such high reconduction rate of linear lesions? Recently, Pembrone reported that a multi-layer of atrial myocardial bundles and interposed fatty fibrosis prevents long-lasting transmural conduction block. Therefore, recovery of epicardial conduction may result in procedural failure. Okay, let's look at the mechanism of post-surgical atrial fibrillation. The most common recurrence mechanism was macro reentry, and the proportion of CTI-dependent perimitral and multi-ripple reentries were similar. And I would like to say about the detailed, I would not say about the detailed mechanism of macro reentry in this time because there are too many nice lectures about the macro reentry using high-density maps. However, I would like to emphasize the role of epicardial conduction route in the mechanism of macro reentry. In this case of post-MACE atrial tachycardia, activation and entrainment map clearly show perimitral reentry, but there is no endocardial potential at the left lateral isthmus area at all because the surgeon already cut this area at the de novo procedure. I guess thick and isotropic epicardial layer, including the ligament Marshall, play some role in the mechanism of this perimitral reentry, and hyper long duration energy delivery eventually terminated this tachycardia. This is another example of a challenging biatrial atrial tachycardia. This tachycardia seems like high septal focus, but was entrained at both LA and right side high septum. So we assume the mechanism of this tachycardia as a reentry involving Bachmann's bundle and both sides of septum. But it is not easy to eliminate this tachycardia because Bachmann's bundle locates on the epicardial side, including sinus. Also, it includes the sinus nodal coronary artery. Next common mechanism of post-surgical atrial tachycardia is focal or micro-reentrant tachycardia. This is atrial tachycardia, but intermittently changed to change the sequence like organized atrial fibrillation. By using rhythmic high-density map, we found the beautiful reentry drivers at the high septal area, and this tachycardia was terminated during anterior linear ablation. Generally, we can observe such a long fractionated potential at the critical point of micro-reentry, and do not forget to try entrainment mapping there immediately before appendage delivery. Another important issue is an extra PV triggers, which is hard to map and ablate. After completion of ablation lesion set, we do isoproteronal provocation test. After induction of AF and the isoproteronal, we terminate it by internal cardio region and wait for 10 minutes of isoproteronal cooling down period. If there is consistent atrial APC and or immediate AF trigger, we try to map and eliminate it as much as we can because extra PV trigger is an important mechanism of recurrence. Repeated shock and extra PV mapping is painful and stressful procedure, but it shows a constant pattern. If it shows a constant pattern of frequent APC, you can map carefully and ablate them all. We systematically reviewed the extra PV triggers in patients who underwent isoproteronal provocation test in over 2,000 patients, And we found extra PV triggers in 12% of de novo procedure and 29% redo procedures. The most common site of extra PV triggers were on septum, coronary sinus, and SVC. And post-surgical valvular AFib, most of the extra PV triggers were localized at the septum and ligament marginal. And also, in 1/3 of extra PV triggers mapped at the redo procedure matched with previous ablation site. 1/3 of extra PV trigger in redo mapping is coming from the previous ablation sites. Okay, as we expected, the rhythm outcome was worse in patients with extra PV trigger in both de novo and repeat procedures, and it was even worse in patients with multiple extra PV triggers than those with a single trigger. Is really isoproton provocation and extra PV trigger ablation valuable? The answer is yes. Professor Young and Kim's group conducted a randomized clinical trial, and rhythm outcome was better after extra PV trigger ablation. We also compared the isoproton provocation and trigger ablation versus just finishing the case without isoproton provocation, and it improved the rhythm outcome in this study. However, the rhythm outcome was still worse in patients who showed the extra PV trigger in spite of ablation lesions, additional ablation. So in conclusion, ladies and gentlemen, post-cardiac surgery valvular AFib manifests as atrial flutter or atrial tachycardia due to severe fibrosis and reduced critical mass despite atrial enlargement. Surgical hemodynamic correction shows positive effects, but post-surgical stiff LA physiology has negative effects on rhythm outcome of valvular AFib. And atrial epicardial muscle bundle and interposed fatty fibrosis are the main mechanism of conduction recovery after MACE procedure or catheter ablation. In post-cardiac surgery valvular AFib mechanism, 63% were macro reentry and 26% were focal or micro reentry. And 1/3 of extra PV triggers occur at the previous ablation site and are associated with poor rhythm outcomes. Thank you very much for your attention.